as a physician, the best part of my job is deprescribing medications. Like I love when people come to me on 3 blood pressure meds and they drop 50 pounds of fat and now they don't need blood pressure medications anymore or cholesterol drugs anymore, or we get them off their diabetes medications. But part of my job is also using whatever tools are necessary or possible to use in these populations. So if I have a type 2 diabetic who is like staunchly in favor of being on Mounjaro, I will heavily walk them through exactly what dietary change they need to follow. And we can use a drug like Mounjaro, especially if the person has wildly elevated blood pressure, blood sugars, and like a food addiction problem, because those medications do help a lot with binge eating disorder and things like that.
Which ones do you use? Which are the most common ones?
So in patients who have type 2 diabetes with an A1C of 6.5 plus, we prescribe Ozempic, Mounjaro, Trulicity, and then patients who have anything less than a 6.5 A1C, they're considered insulin resistant, pre-diabetic, metabolic syndrome without the diabetes. They would be on something like Wegovy or Zepbound or Saxenda. So we're prescribing, like it's just me and my nurse practitioner in the office, and we're prescribing medications to a portion of our patients, depending on how they present and their own like personal desires and what works for them.
Mm-hmm. And so are they temporary or, are you putting people, because I think that would be, if I were considering any of those drugs, that would be my first question. Is this a lifelong thing or is this a temporary thing?
Yeah, I think there's like 2 different camps in this. So there's people who look at weight loss injections. So there's like the group of Obesity Medicine Association, Harvard, Blackburn, like these large bodies of obesity medicine that like created the ABOM, the American Board of Obesity Medicine. And they say things like obesity is a chronic disease and these medications are lifelong, in the way that patients who are type 2 diabetic, this is like the same group of people who will say you're type 2 diabetic, it's a lifelong disease that requires lifelong treatment, which is often inclusive of medication. Then you have the camp of like Low Carb USA, Society of Metabolic Health Practitioners, who are on the side of like, if you're gonna use a drug like a GLP, it should be like a temporary tool to get you to your goal, and then you kind of like wean off the medication or microdose it, or basically only on it if you absolutely need it. I see both sides and I attend both conferences. Like I have patients who have such severe issues with binge eating disorder, emotional eating issues. They just lead stressful lives. Like it's a busy mother of 3 who eats her feelings, right? So that person has dieted a million times in her life, including keto diets, and it's like nothing has ever worked, but a low dose of Zepbound has kept her cravings and food noise at bay and allowed her the ability to now follow a low carb diet. It's not like you take a drug and eat pizza all day and you're skinny. Like we wish that existed. There's no such thing, right? So really does this medication keep their disordered eating patterns at bay and keep their food noise at bay? And if so, great. Maybe they want to come off of it after a year, maybe they don't, but we really do see an issue with coming off medications, because if your food noise is kept at bay and you're doing so well and you're at your goal, and then you get rid of that molecule that's binding to those receptors and decreasing all that craving for carbs, unfortunately, a lot of people gain their weight back. And if you look at studies like randomized controlled trials with these shots, 2/3 of weight regain is what we see. So you lose, say, 50 pounds, 2/3 of that 50 pounds comes back after cessation of the medication. In our clinic, because we take such a low carb focus, it is not 2/3 of patients gaining 2/3 of their weight back. It really is like a 50-50 thing. So about half the patients who stop the medication stay low carb, keep their being low carb, as you know, keeps your food noise at bay because you're not having these like wild swings in blood pressure, blood sugar or insulin anymore. So following a low carb or keto diet, like long term, is extremely helpful with being able to come off that medication. But then you have the people who, as soon as they come off, food noise returns and they feel like they have to go back on it, like restart it. So basically signing up for a drug like Zepbound or Wegovy or Ozempic or Mounjaro is signing up for the potential of feeling stuck on the medication, which is fine, right? Because there are these people who are on it long term, and we have longer term studies for drugs like Trulicity. 7 to 10 year data don't show any increased risk of cancers or anything like that. There is a black box warning for thyroid cancer, but it's not because of any increased incidence of thyroid cancer. So seems to be, what I usually say to people is, seems to be safe long term from longer term 7 to 10 year data with Trulicity, which is a GLP-1. And then I say, you are taking the risk of being on the medication for long term if you do start it, right? If you don't start a medication and you do lifestyle changes only with, say, low carb and intermittent fasting, then obviously you're not going to take the risk. But if you are starting a drug like that, there's a risk involved of, yes, you may end up on this long term, because without it, the food noise comes back.
Um, I think I don't know if you see children, adolescents who are
I
obese.
do. We see 15 plus. So I used to do family medicine. So I used to see like babies and really young kiddos in my practice. But now with this clinic that I'm working in, like I work at a nonprofit hospital organization. And so their policy is set forth as age 15 plus.
And is it the same sort of strategies for 15 plus? Say a 15-year-old
Usually with
kid?
21 or under, our primary intervention is, well, actually, no, with everybody, right? All patients, are the primary intervention is lifestyle change. But we are much more likely to like reach for these tools like medications in an older group. If you do follow Obesity Medicine Association or any of the big boards of obesity medicine, they all say 13 plus to start injectables. But for no age group is injectable the first intervention. Like that shouldn't be, in my practice, it's not, will not be, has never been the first intervention. However, in many practices nationwide, hundreds and thousands of doctors and nurse practitioners nationwide, it's their first most important intervention, are injectable weight loss drugs. But how does someone learn how to eat long term, learn about their body type, learn about like hormone imbalances, insulin resistance, metabolic health? You can't learn about that stuff if there's a shot first and then trying to learn the diet later. It should be like dietary intervention first. Then that is one of many tools, the way intermittent fasting is a tool, that is one of many tools that can be added into the program.
So, hormonal and biological barriers to fat loss. So, one of the most important hormones, and we discussed that, is insulin. And if it's consistently high over decades, maybe even a decade, then you are becoming hyperinsulinemic and therefore insulin resistant. That's clear enough. What other hormones play a
So
role?
it's not just about the insulin, even though that's such an easy. So I use insulin in explaining to patients because I think it's easiest to understand that like having extra glucose, having extra insulin, it's now a fat deposition hormone, you're now resistant, right? But if you get into all the biochemistry, we have ghrelin, the hunger hormone, we have leptin, the satiety hormone, we have GLP-1, glucagon-like peptide 1. That's the one that's involved and implicated with these injectable weight loss drugs. GIP, which is gastric inhibitory peptide, which is what Mounjaro and Zepbound bind to. So there are like a cascade of hormones involved in weight gain and weight loss, also including thyroid hormones. There's estrogen around menopause. Like, good Lord, there are so many things going on. And honestly, so many things going wrong when you're eating the wrong foods for your body. So if you're primarily looking at processed crap and that's what your intake is, then tons of these hormones, I don't know, 2/3, all of them are going to be out of whack. Like you're going to have an inappropriate release of ghrelin, the hunger hormone, if you're eating something like processed Chinese food and ice cream for dessert. You're going to have an inappropriate release of ghrelin, the hunger hormone, 2 hours later and already be hungry again. Whereas if you're having something like a 16-ounce steak, you're not going to be hungry 2 hours later because you have a great suppression of ghrelin, the hunger hormone. So I will touch on things like ghrelin or leptin, the satiety hormone, with patients. But I don't even, is like, I've always said, is there even a need to get into the nitty gritty of biochemistry with each and every patient out of 3,000 people? Not really. You just need to know which foods are breaking your metabolism, right? Like you just have to know what things are ruining it. And the best way to explain it is with sugar and insulin, but there's obviously so many more. And there's probably more hormones we don't even know about because they're currently being like researched right now, like amylin, for example. Like there's all these hormones that they discover and research, and now they're trying to find like medications that bind to them to try to like decrease hunger, and it's crazy that the world of obesity medicine and the research that goes into it is crazy. And I don't even know where we'll be at, 2 years from now in terms of our understanding of like the GI tract and how it has a mind of its own. Like it has its own neurological system and its own hormonal system. Everyone always thinks of like the endocrine system when it comes to hormones, but the GI tract has its own hormonal system.
Yeah. Uh, it's quite complex. So in chapter